Hi, everybody. Here we are, chapter 24, Radiology. So we're moving right along. This is a fun chapter because it kind of overlaps into a lot of other ones, and you've already used a bunch of these. And so it's not going to be a whole bunch of new material for you. Remember that radiology is that branch of medicine that uses radiant energy to diagnose and treat patients. And a specialist in radiology is, of course, a radiologist, doctor of medicine. They can provide services to patients independent or in conjunction with another doctor of a different specialty. The radiology subsections are all broken down. They're listed here. They start with diagnostic radiology and end with nuclear medicine. The terms fluoroscopy views inside the body projects onto a television screen. These are live images in which the physician can view the function and the structure of an organ. And remember, we've used fluoroscopy for a lot of other things as well as guidance in the past. So the study of the function of the organ is physiology. The study of the structure of the organ is anatomy. MRI, magnetic resonance imaging, uses magnetic energy to view soft tissue structures. So, for example, after the car accident, I had a 72148, an MRI of my lumbar spine canal, where they found the extruding disc compressing the nerve root. So, you need to remember that these MRI codes are found in the body area that is being viewed. So, that anatomic site is important. This view is this MRA, Renaissance angiography. So, this is one application of an MRI that provides visualization of blood flow as well as images of normal and diseased blood vessels. So while the top of this slide says MRI, the actual picture is showing you an MRA. This is your blood flow. Topography or CT. Tomography is used to view a single plane of the body. So a tomographic or a CT scan of the head or the brain. A CT scan of a lung cancer, carcinoma. So this is no longer a lung mass. This is now being confirmed on CT, which is the purpose, again, of using this kind of testing. Biometry, the application of statistical methods to biologic facts. So the use of the ultrasound echocardiograph in the biometry of the eye. Ultrasound diagnostic non-invasive procedures are performed to determine the composure and of the contours of the ocular and orbital structures in this case. The next slide is talking about the planes of the body. Great illustration in your book on the top of page 627. Position is the way the patient is placed, and projection is the path in which the X-ray beam travels. So, for example, an example of a position, the patient is lying on his or her front, the anterior body. But the site of the entrances and exits are not specified, so that wouldn't be very easy to code. The example of a projection, anterior O posterior. The X-ray beam enters the patient's body at the front and exits from the back. Now you've got a complete picture of how you're going to code that. Terminology. Radiology includes a wide variety of terms and abbreviations specific to planes, positions, and projections. So you need to read those very carefully. Some of the terms are proximal, distal, lateral, dorsal, ventrals, prone, dubicus, oblique views, and tangential projection. So you need to really pay attention to all of those terms. On page 627 through 631, there are a lot of these terms, and if you do that exercise 24-2, it will help you understand planes and make it a little clearer to you. Component coding, of course, we have the three parts of this. We're going to have technical, professional, technical, and global, and you've heard all those terms before. So your professional coding is if the physician part includes the supervision of a technician and the interpretation of the results. The technical component is the technologist services, the equipment, the film, and the supplies. You only append the modifier TC if only the technical portion is being coded. The component modifiers are, if only the professional component is being coded, then you would append the modifier 26. So if a radiology clinic employs its own technologists and radiologists, the global procedure can be reported. But if it's only the doctor's going over to the hospital and reading all of the echoes, he doesn't own the equipment, you'd put that modifier 26. I hope that is clear. The and then of course here is the technical component was provided to append the modifier TC to the code. Remember that these modifiers are only for CPT and HCPCS codes. They are not to be appended to an ICD-10 code. Somebody did that in their homework last chapter, and consequently the answer was wrong. Global procedures, the third-party payers usually reimburse 40% for the professional component, 60% for the technical component. So thus there is an incentive. In order to capture this 100% of the global procedure, you need to own the equipment and employ the technicians and the physician who is going to code it. Contrast material. If the statement says with contrast, that implies the injection is built into the code, not coded separately. One of your answers for your last chapters talked about the injection code, and it was not bundled, so you needed to code it separately. So, and then you also need to know, with contrast, how was it administered? You need to know those kinds of things. Is it intravascularly, interarterially, or intercatheterly? So you need to know all of those things when you're coding that, okay? Your contrast material also has guidelines. They're issued by CMS. It's called MUEs. They're medically unbelievable audits. Used to be called unbelievable. Now they're called medically unlikely edits. So for example, if you coded a hysterectomy and your patient was a male, that probably would hit that edit, MUE edit. So you're not going to probably have that work. You need to really pay attention. And that's why it's so important for the front desk to enter all the information correctly and the back desk to code correctly. And for the MAs, this is going to come into your field also if you're working with these. So overall, the radiology subsection is listed again as we break them all down. So diagnostic radiology, complete in a code means that in a radiology section means that all the views were taken of a specific body site. Most standard radiographic procedures include this code. Codes are often divided whether or not contrast material was used, and then coded further divided on the number of views. So this subsection also includes plain X-rays, CTs, MRIs, and MRAs. Diagnostic radiology is used to diagnose a disease or to monitor the process, the disease process. Are you in progression or remission? Is the treatment working or isn't it? So we have to follow up with this kind of testing. Diagnostic procedures include X-ray, CT or CAT, MRIs, and angiography. Now, when we did cardiology, of course, we already have coded these, so we know what those are. Computerized axial tomography. This is an X-ray taken in sections, and then the computer reconstructs and enhances the image. So, for example, if you did this to produce a three-dimensional construct, which can then be used to study the internal structure. So it's pretty amazing the way this all can work. The magnetic resonance imaging, MRI, again, we've already talked about that, but you need to know whether or not you're using contrast. Angiography, used to view the vessel obstructions. The dye is injected into the vessel. We talked about this when we talked about cardiology. So the dye is injected into the vessels to add contrast, and it can be done through your brachial artery or through your femoral artery. The dye is used to identify abnormalities. Angiography, it's taking a picture of the aortic arch and the brachiocephalic vessels. This is what he's looking for in this picture is probably an aortic aneurysm. More common in men, more common in smokers. So just another reason not to ever smoke. Angiography, radiologist uses these to diagnose vascular conditions. So, for example, malformations, or has there been a stroke, or is there a myocardial infarction? What kind of a blockage are we looking at? Remember that if you take fewer than the total number of views specified in the code, you need to use that modifier 52, showing that it was a reduced service. So, if, for example, you were taking fewer than normal, and you've appended this code, unless there's a code for a smaller number of views that exists. Mammography codes are difficult. 77065 is for a unilateral. For example, if there was a shadow found on a screening mammography and then just one side was repeated. 77066 is the bilateral code, and these are diagnostic. views, and 77067 is the code for screening, bilateral, and 2 views of each breast. And then we're into our diagnostic ultrasound codes. These are on page 638. We're using high-frequency sound waves to image anatomic structures. An audible sound waves bounces off the body tissues and then are recorded to give information. Of course, we found this technology during World War II when we were trying to find submarines. So the diagnostic ultrasound is referred to often as a Doppler ultrasound. The sound goes through solids or liquids and is a specific version of ultrasound. It was named for Johann Doppler, who was an Austrian physicist. Your diagnostic ultrasound here is showing a gallstone. So this is, it's showing, they're very hard, and so they're shown as a stone, but we've also called them what? A calculus. It's telling the physician there is something there that does not belong. The subheadings of diagnostic ultrasound, primarily based on anatomy, and many notes in these subsections are direct you to the correct code assignment, so you need to read those carefully. There are 3 locations for ultrasound services in your CPT book. Radiology services, which we're talking about today. These are for diagnostic ultrasound services. In the medicine codes, there's vascular studies, and in the medicine codes, there's echocardiograph. So you need to know exactly which one you're looking at. An interventional radiologist combines the radiology and the surgeon. He provides total procedure, for example, for a cystography with contrast. So he's going to be the one doing those. He's a specialist who's skilled in both of these fields and has gone on to extra schooling to know all of this. They're very commonly used in cancer treatment. So the ultrasounds, there's different modes and scans. So these are difficult. You need to really pay attention to these. The physician's note must specify what type of ultrasound was used. You need to understand these definitions. So if it's an A mode or an A scan, it's just one-dimensional study. If it's M mode, think of M as movement. It's the one-dimensional measurement procedure with movement of the trace to allow amplitude and velocity of moving echo-producing structures. B scan is 2-dimensional. A real-time scan is a different kind. An A and B scan can be performed together, but generally has to be approved if you're doing your pre-authorizations. Medical necessity needs to be documented. So again, A stands for amplitude. The technique used to map the structure online displays one-dimensional image. So amplitude. M, motion. So just think of it as motion. B, brightness. So this technique is used to display movement of the tissues and the organs. It's also known as a grayscale ultrasound, and it produces a 2-dimensional image. Why is it known as a grayscale? The strong signals display as black, and the weak signals display as a lighter shade of gray. A real-time scan, this technique is used to display both the structure and the motion with time of organ and tissues. So think of your heart beating, and so when you have a real-time scan, you're watching your heartbeat, you're watching the blood flow go through. So you're watching both the organ and what's happening in the vessels. The extent of the study, it's often determines your code. So just as with all of your colonoscopies, what the extent of the study was depended the codes, this is the same. So what would happen if you didn't code the furthest extension? You would have lost revenue, so you want to make sure you do that. So a complete scan scans the entire body. A limited scan just scans one organ, and a follow-up or repeat scan is a limited study of the body that was scanned previously. So you need to make sure that you're reading those words very carefully. Radiology guidance, breast mammography, all of these codes are listed here and broken down for you. So radiology guidance we've used before. We've used fluoroscopy before. We've used MRI before. Mammography, there are those codes. Bone joint studies such as bone density and joint survey. Bone density, you're looking for osteoporosis. Radiology oncology, therapeutic use of radiology. So these subheadings are divided upon the treatment. Radiology oncology is a huge field. The initial consultation prior to decision to treat is reported with an E&M consultation code. Outpatient codes are here, inpatient are there, and they're listed in your CPT under your E&M section. The follow-up consultation criteria you need to document needs to be documented as to who and why. Is the patient inpatient, outpatient? Remember all of our little rules for E&M coding from before. Clinical treatment planning. This includes the interpretation of special testing, the tumor localization, and determination of the treatment volume. The next part of this is talking about the choice of the treatment method, determining the number of treatment ports, selection of the treatment devices, and other necessary procedures. This code covers the physician planning on how to best treat his patient or her patient for cancer. There's 3 different types of treatment plans for all patients requiring radiation therapy. There's also 3 levels of billing for a treatment period. There's codes for 1, planning, 2, simulation, 3, the isodose plan, 4, the devices that will be used, 5, treatment management, and 6, radiology delivery. So all of these things all add up, and that's why this kind of treatment is so terribly expensive. So that's the levels of billing, but here's the levels of planning. So there's a simple level of planning: 1 treatment area, 1 port, or 1 set of parallel ports. Intermediate is 3 or more ports, 2 separate treatment areas, or multiple blocking. Levels of planning continued could talk about the complex. There's complex blocking, custom shielding blocks, tangential ports, special wedges or compensators, 3 or more treatment areas, and special beams. Complex is, of course, the most labor-intensive of the 3 levels of planning, and you have to have great documentation to show all of this. Most commonly, this level of planning is in children, because we need to shield block parts of their body. There's just lots of things that have to go into this. If it's an unlisted procedure, 77299, go back to your provider and say, I need more information. Simulation. This determines the placement of the treatment areas or ports for radiation treatment. It does not include the administration. There's 4 levels of simulation: simple, intermediate, complex, and 3D. So you need to know exactly which level of this is being performed. Medical radiation physics, dosimetry, and treatment devices and special services. These are all decision-making services of the physicians. He's going to decide the treatment. He's going to talk about dose calculation and placement and development of the treatment device. Stereotactic radiation treatment delivery. Remember those codes? We talked about those when we talked about stereotactic, when we talked about other body anatomic areas. We've already, so that this is something that you're familiar with. But just make sure that the codes have the instructions for coding for you. Radiation treatment delivery. Here we have radiation, neutron, proton beams, technical components, MEV, electrons, neutrons, and protons. These are all the units to deliver the radiation treatment are the MEVs. That's going to be a question. I'm sure it's on your test if it isn't in your homework. And this code would only be billed out if the radiation treatments were given every day for a set number of days. You need to know how much radiation is being delivered, what type of radiation. They all go into assigning the code. The number of areas treated, the ports involved, the blocks involved. So there's lots of, on your coding sheets for coding this type of information, you're going to have columns, much like an Excel spreadsheet, that's going to show you all of the things that you need to make sure that you're coding for this so that you hit them all. So just make sure that you're finding all of the information in your question before you try to code it. Reporting radiology treatment management, the physician portion of the services, all the things that go into what he does. He reviews the port films, the dosimetry, the dose delivery, treatment parameters, treatment setup, the patient examination for the medical E&M, reports in units of 5 fraction. Unless the last 3 or 4 fractions are at the end of the treatment, count the last 3 or 4 as an additional fraction. Brachytherapy, we've talked about this before, the placement of radioactive material in or around the site of the tumor, so within the body cavity or within the tissues. We talked about that with prostate cancer. The source radioactive element delivers the radiation over time, so you can have seeds, ribbons, or capsules, and these will be embedded, the seeds are embedded on a tape. So you need to know that too. The number of sources applied, 1 through 4, is simple, intermediate is 5 through 10, and complex is 11 or more. And then our last section is nuclear medicine. Placement of radioactive materials into the body and measurement of emissions. This is used both for diagnostic and treatment. In our cardiac section, we talked about a nuclear stress test in which the patient is giving that medication. He's giving the nuclear dose. They wait a specific period of time. They scan them again and see what that radioactive material is showing during the monitoring of this test. These codes are, again, divided primarily on organ system, and the exception is therapeutic. And then the last kind is a PET scan. It's based on the location. It's non-invasive imaging. And normally they do this to follow if the treatment is being successful that we have already diagnosed. Yay! That's our last slide for radiology.